Hello and welcome. I'm Professor Shaibu Oricha Bello, and it's a real pleasure to have you here. In this video, I want to take you right through the antihypertensives, from the very first principles to the finer points that examiners love to test. My aim is simple. By the time we finish, you'll be able to look at any patient with high blood pressure and know exactly which drug class to reach for, why it works, and what to watch out for. We'll cover every major class, the mechanisms, the key side effects, and the first line rules, the board exam essentials, all in one place. So grab a pen, get comfortable, and let's build this knowledge together step by step. Let me start by setting the stage, because I want you to appreciate just how important this topic is. Roughly half of all adults live with hypertension, and yet only about 1 in 5 of those we treat actually reach their blood pressure goal. That gap is where you, as a clinician, make a real difference. Remember too that high blood pressure is the single biggest modifiable risk factor for stroke, heart attack, heart failure, and chronic kidney disease. Now look at the classification table, because the numbers changed in 2017. Normal 1 to 20/80. Elevated is 100 to 129 systolic with a normal diastolic. Stage 1 hypertension now begins at 130/80 and stage 2 at 140/90. Anything above 180 or 120 is a crisis. Here's the pearl I want you to hold onto. Those thresholds dropped in 2017. So diagnosis now starts at 130/80. But whether we actually start a drug depends on the patient's overall cardiovascular risk, not the blood pressure number alone. Before we memorize a single drug, I want to give you a framework, because this one equation will organize everything that follows. Blood pressure equals cardiac output multiplied by systemic vascular resistance. Every antihypertensive we discuss lowers one or both of those two things. So group the classes by their target. Some lower blood volume, that's the diuretics. Some lower cardiac output, beta blockers, and the non-dihydroapiridine calcium blockers. Some lower vascular resistance, the ACE inhibitors, ARBS, dihydroapiridine calcium blockers, alpha blockers, vasodilators, and the renin inhibitor. And some turn down sympathetic tone centrally, clonidine and methodopa. And here's the mnemonic that ties it together. The first line classes spell A, B, C, D, ACE inhibitor or ARB, beta blocker, calcium channel blocker, and diuretic. In most patients, we start with A, C, or D. Let's meet that first line up properly, because these 4 letters will carry you through most of clinical practice. A is for the ACE inhibitors and ARBS, which block the renin-angiotensin system. B is for the beta blockers, which reduce heart rate and contractility. C is for the calcium channel blockers, which either dilate vessels or slow the heart. And D is for the diuretics, which deplete volume, led by the thiazides. Now I want you to notice something important about the B-beta blockers are on the list, but they are not a first-line choice for uncomplicated hypertension on their own. We reserve them for patients with a compelling reason: after a heart attack, in heart failure with reduced ejection fraction, or for rate control in atrial fibrillation. Keep that distinction sharp, because examiners love to catch you out with it. Let's begin with the diuretics, and the thiazides come first because they are true workhorses of hypertension therapy. Mechanistically, they block the sodium chloride cotransporter in the distal convoluted tubule. That reduces sodium and water reabsorption, so plasma volume falls, and over the longer term vascular resistance drops as well. Your prototypes here are hydrochlorothiazide, chlorthalidone, indapamide, and metolazone. For the side effects, think of the low electrolytes, low potassium, low sodium, low magnesium, and then the metabolic disturbances I call the hyper-GLUC. Raised glucose, raised lipids, raised uric acid, and raised calcium. There's also a sulfur cross-reactivity and photosensitivity. Be cautious in gout, in refractory hypokalemia, and remember they lose effectiveness once kidney function is low. The high yield point chlorthalidone is longer acting and more potent than hydrochlorothiazide. And note that thiazides raise calcium, whereas the loop diuretics do the opposite. Now the rest of the diuretic family. The loop diuretics, furosemide, bumetanide, torsemide block the sodium potassium 2 chloride transporter in the thick ascending limb, and they are the most potent diuretics we have. Their side effects include low potassium, low calcium, autotoxicity, dehydration, and gout. Then the potassium sparing agents, amiloride and triamterene, block the sodium channels in the collecting duct. They're weak on their own, but useful to offset the potassium loss of other diuretics. Just watch for hyperkalemia, and the aldosterone antagonists, spirolactone and iplerenone, block the aldosterone receptor. These are key players in resistant hypertension and in heart failure. Again, hyperkalemia is the concern, and spironolactone can cause gynecomastia. Here's a memory hook. Loops lose calcium, thiazides keep calcium. And remember, spironolactone is our first line ad when hypertension proves genuinely resistant. Now to the A of our lineup, the ACE inhibitors, the PRILs. They block angiotensin converting enzyme, so less angiotensin II is formed. That means vasodilation and less aldosterone. But the enzyme also breaks down bradykinin, and when we block it, bradykinin accumulates, and that gives us the classic dry cough. Your prototypes are lisinopril, enalapril, ramipril, captopril, and benazepril. The side effects to no cold are that dry cough in about 1 in 10 patients, hyperkalemia, angioedema, first dose hypotension, and a rise in creatinine, especially dangerous if there is a renal artery stenosis. The absolute contraindications are pregnancy because they are teratogenic, bilateral renal artery stenosis, prior angioedema, and a high potassium. The high yield message. These drugs are renoprotective in diabetes and chronic kidney disease with proteinuria. But never ever combine an ACE inhibitor with an ARB. You only stack up the hyperkalemia and the renal harm. The ARBs, the Zartans, are the natural partners to the ACE inhibitors. Instead of blocking the enzyme, they block the angiotensin II type 1 receptor directly, one step further downstream. And because they leave bradykinin alone, they give us far less cough and far less angioedema. The prototypes are losartan, valsartan, candesartan, irbesartan, and olmesartan. The side effect profile mirrors the ACE inhibitors. Hyperkalemia, first dose hypertension, a rise in creatinine, but the cough largely disappears and angioedema is rare. The contraindications are the same: pregnancy, bilateral renal artery stenosis, and hyperkalemia. So here's how I want you to think about it. ARBs give you the same efficacy and the same kidney protection as the ACE inhibitors, but without the cough. That makes them the go-to whenever a patient simply cannot tolerate a pill. On to the C, the calcium channel blockers. And the crucial exam point is that there are two very different subfamilies. The dihydropyridines, the dipines, amlodipine, nifedipine, felodipine, nicardipine, act mainly on vascular smooth muscle. They're potent arterial vasodilators, and their side effects reflect that peripheral edema, flushing, headache, and a reflex tachycardia. The non-dihydropyridines, verapamil and diltiazem, act on the heart itself. They slow the rate and reduce contractility, which is why we use them for rate control. Their side effects are bradycardia, AV block, constipation, especially with verapamil, and they can worsen heart failure with reduced ejection fraction. And here is the combination I want burned into your memory. Never combine a non-dihydropyridine, verapamil or diltiazem with a beta blocker. Both slow the heart, and together they risk severe bradycardia and heart block. Now the B, the beta blockers, the orals, they block beta-1 receptors, reducing heart rate, contractility, and renin release. Know your subtype is the cardioselective agents: metoprolol, atenolol, bisoprolol. Favor beta-1. The non-selective ones like propranolol act more broadly, and carvedilol and laetolol add alpha-1 blockade on top. Their compelling indications are after a heart attack, in heart failure with reduced ejection fraction, for atrial fibrillation rate control, and in angina. The side effects to remember are bradycardia, fatigue, reduced exercise tolerance, bronchospasm, and cold extremities. Importantly, they mask the warning symptoms of hypoglycemia, and they can cause sexual dysfunction. Never stop them abruptly. You risk rebound tachycardia and ischemia. And use caution in asthma and acutely decompensated heart failure. The high yield point again, not first line for uncomplicated hypertension. And in heart failure, only 3 beta blockers actually reduce mortality: carvedilol, metoprolol succinate, and bisoprolol. Let's cover the sympatholytics. First, the alpha-1 blockers, the osins: prazosin, doxazosin, terazosin. They block alpha-1 receptors, giving both arterial and venous vasodilation, and as a bonus they relax prostate smooth muscle, which helps men with benign prostatic hyperplasia. Their signature side effect is first dose orthostatic hypertension, along with dizziness and reflex tachycardia. Then the central alpha-2 agonists, clonidine and methidopa. By stimulating alpha-2 receptors in the brain, they reduce sympathetic outflow, lowering both cardiac output and vascular resistance. Watch for sedation and dry mouth, and remember that stopping clonidine abruptly causes dangerous rebound hypertension. 2 high-yield facts. Methidopa is a preferred agent in pregnancy. And while alpha-1 blockers help men with prostate symptoms. They are add-on agents only. The ALI trial showed worse heart failure outcomes when they were used as first line. Now the direct-acting agents. The direct vasodilators, hydralazine and minoxidil, relax arteriolar smooth muscle directly. Because they drop resistance sharply, they trigger reflex tachycardia and fluid retention. Hydralazine can cause a drug-induced lupus, and minoxidil famously causes hirsutism. Clinically, the hydralazine plus nitrate combination is valuable in heart failure with reduced ejection fraction, particularly in black patients, and hydralazine is also used in pregnancy. Then the direct renin inhibitor, aliskiren, which blocks the renin-angiotensin system at its very first step. Its side effects are hyperkalemia, angioedema, and diarrhea. It's contraindicated in pregnancy, should not be combined with an ACE inhibitor or ARB, and is best avoided in diabetes. The overall message: these are later line agents. And notice the recurring theme: every drug that blocks the renin-angiotensin system, whether it's an ACE inhibitor, an ARB, or aliskiren, is teratogenic and must be stopped before or very early in pregnancy. Let's now put it all together into a treatment sequence. Step 1 is always lifestyle, alongside an honest assessment of cardiovascular risk. The DASH diet, sodium restriction, weight loss, exercise, and limiting alcohol. We commit to drug therapy when the pressure is at least 130/80 in a high-risk patient, or at least 140/90 in anyone. Step 2 is to start a first-line agent, a thiazide, an ACE inhibitor or ARB, or a calcium blocker. In black patients without heart failure or kidney disease, we favor a thiazide or a calcium blocker first. Step 3, if the patient is more than 20/10 above goal, don't wait, start 2 agents, often as a single pill combination. And step 4, for resistant hypertension, add spironolactone, then consider a beta blocker, an alpha blocker, or a central agent, but always confirm adherence and rule out secondary causes. The rule to remember: aim generally for under 130/80 and never stack an ACE inhibitor, an ARB, and aliskiren together. Pick just one blocker of that system. This slide is where the exam is often won or lost, so let me walk you through it. The idea of a compelling indication is simple. The patient's other condition tells you which drug to choose. Diabetes or chronic kidney disease with proteinuria points you to an ACE inhibitor or ARB because they protect the kidney by lowering pressure inside the glomerulus. Heart failure with reduced ejection fraction calls for the full quartet. An ACE inhibitor or ARB, a beta blocker diuretic, and a mineralocorticoid antagonist, because that combination saves lives. After a heart attack, reach for a beta blocker plus an ACE inhibitor or ARB to limit remodeling. For atrial fibrillation rate and control, a beta blocker or a non-dehydropyridine calcium blocker. In black patients without heart failure or kidney disease, a thiazide or calcium blocker. Osteoporosis actually favors a thiazide since it conserves calcium. And in older men with prostate symptoms, an alpha-1 blocker can be a useful add-on. My exam tip: the question rarely gives you a plain hypertensive patient. The comorbidity is the answer. Diabetic proteinuria means an ACE inhibitor or ARB every single time. Let's tailor our therapy to specific groups because one size never fits all. In pregnancy, the safe agents are labetalol, nifedipine, methadone, and hydralazine, and the drugs to absolutely avoid are the ACE inhibitors, ARBs, and aliskiren because they're teratogenic. In diabetes, favor an ACE inhibitor or ARB, especially with albuminuria, and be wary of high-dose thiazides that push glucose up. In chronic kidney disease, again an ACE inhibitor or ARB, switching to a loop diuretic once kidney function is low, and avoid the potassium-sparing agents. In the elderly, a thiazide or calcium blocker works well, but start low and go slow to avoid falls. In black patients, a thiazide or calcium blocker is first line unless there's heart failure or kidney disease. And in heart failure, it's that 4-drug combination again, while steering clear of the non-dihydropyridine calcium blockers. The must-know for your exam is the pregnancy safe list. I remember it as LALALAMI-HI. Labetalol, nifedipine, and methodopa, hydralazine. And the renin-angiotensin blockers are absolutely contraindicated. Now to the crisis, and you must separate two things clearly. A hypertensive urgency is a pressure above 180/120 with no end organ damage. Here we lower the pressure gradually over 24 to 48 hours using oral agents such as labetalol or amlodipine. A hypertensive emergency is that same high pressure but with end organ damage, and that patient belongs in intensive care on intravenous drugs, where we lower the mean arterial pressure by only about 10 to 20% in the first hour. Now your intravenous agents. Nicardipine and clevidipine are smooth, titratable calcium blockers and a great first choice. Labetalol and esmolol give combined alpha and beta blockade, ideal in aortic dissection and in pregnancy. Nitroprusside works on both arteries and veins, but watch for cyanide toxicity. And nitroglycerin is your choice in pulmonary edema or acute coronary syndrome. The danger to respect: drop the pressure too fast and you can cause a watershed stroke, a heart attack, or even blindness. And in aortic dissection, reach for esmolol or labetalol first to blunt the shearing force on the aortic wall. Let's do a rapid fire recall of the side effects, because these are pure exam gold. For the ACE inhibitors, think of the word capitopril, cough, angioedema, proteinuria, taste changes, and hypertension plus hyperkalemia. For the thiazides, remember the hyperGLUC, raised glucose, lipids, uric acid, and calcium, together with the low potassium, sodium, and magnesium. The loop diuretics give you ototoxicity and low calcium. Again, loops lose calcium. The dihydropyridine calcium blockers cause peripheral edema, flushing, and reflex tachycardia. The non-dihydropyridines cause bradycardia, constipation with verapamil, and AV block. And the beta blockers bring bradycardia, bronchospasm, masking of hypoglycemia, and fatigue. Pause the video here if you need to. Say each of these out loud, because on exam day it's this instant recall that earns you the marks. Let's bring it home with the 4 ideas I most want you to carry away. The first line classes are A, B, C, D, a C inhibitor or ARB, beta blocker, which we reserve, calcium blocker, and diuretic. And in most patients we start with AC or D second. Let the comorbidity choose the drug. Diabetes or kidney disease points to an AC inhibitor or ARB. Heart failure needs the 4-drug combination. And atrial fibrillation calls for a beta blocker or a non-dehydropyridine calcium blocker. Third, know the dangerous combinations code. No ACE inhibitor with an ARB. No non-dehydropyridine calcium blocker with a beta blocker. And only ever one blocker of the renin-angiotensin system. And fourth, the pregnancy safe list. Antihypertensive, labetalol, nifedipine, methyl-dopa, hydralazine, while the renin-angiotensin blockers are teratogenic. That's the whole picture. If this helped you, please like the video and subscribe, because next up we tackle the antianginos and the heart failure drugs. I'm Professor Shaibu Orichabello. Thank you for studying with me, and I'll see you in the next one.